All right, good afternoon, everyone. Thank you so much for joining us for the February Medina County Safety Council meeting. We have an action-packed agenda, so we do want to go ahead and get started. We are going to ask that you keep yourselves on mute and that you turn your cameras off so that we can maximize our bandwidth for this presentation today. We do have almost 50 people that are joining us for the presentation. So we are excited to present February's Safety Council meeting. We're going to do things a little bit differently today. First of all, we're going to start off with Dr. Richard Shewbridge, who is president of Cleveland Clinic, Medina Hospital. He has contacted us and going to give a special presentation on the COVID vaccine. And then we will go to our presenters on Stop the Bleed. And then we will follow up with Carrie and myself doing any Safety Council information as well as the BWC update. Again, we are recording this as we do every month. So following this meeting, the recording will be sent to you via email that you can share with any of your team members. So Dr. Shewbridge, I'm going to turn over the floor to you.
Thanks, Stephanie. Hello, everyone. I wanted to just give an update on COVID vaccines and talk a little bit about it. So, and we're getting this message out to groups across the county to make sure that as many folks are getting the vaccine as possible. It's going to be very important that we get a majority of people vaccinated to help control the spread of the virus and keep it from becoming a permanent part of our daily lives. So just wanted to just catch people up on how it's going. We're doing vaccinations here at Medina Hospital. You do not have to be a Cleveland Clinic patient to get it here. You just have to be invited through MyChart. So you do have to set up a MyChart account with the Cleveland Clinic to get the vaccination invitation from our site. We're giving it here, but there's also lots of other sites in the county at the local pharmacies and also at the health department. So I think what we need to keep in mind is some perspective here of where we are. It seems like we've been doing this forever, but keep in mind that to have a vaccine this early in the face of a worldwide pandemic is probably going to be considered in the long run one of the greatest miracle science accomplishments mankind has ever done. So this is something that we should be spreading the word on to everyone to make sure we can get as many people vaccinated as possible. Now, we can't do everybody at once, and we are under the guidance and control of the governor as far as who goes next. But basically, we did some healthcare providers first, and then we're doing people with advanced age and medical conditions, and then the very large second group is people who have chronic medical conditions that would need the vaccination due to their higher risk, and then the third group was to be high general population, so we can get as many of those as possible. So we have to sort of go in an order here, but we're making some good progress, and we had some hiccups with supply, but we're trying to get as much as we can into the arms of our fellow citizens as possible. So it's a great, the one that we're using now, the Pfizer and the Moderna vaccines are excellent at controlling the disease and preventing severe COVID disease, which is what you really want to be sure your vaccine does, is prevent severe COVID disease and mortality. Safety data on these vaccines has been fantastic. They really put the effort in up front on these vaccines to make sure that it's safe to give. The safety data is excellent. And then the efficacy, or how well it works, is actually very, very good with both of the vaccines. The two-stage vaccines we have right now, the efficacy is at 95%. So it works 95% of the time to help reduce that risk of severe disease. Some side effects, particularly with the second dose, as your immune system wakes up to seeing that second dose, you might have some mild side effects that are generally over within 24 hours after the shot, but might lay you low for a little bit. But majority of patients don't have that problem and are doing well with the vaccine, and we haven't seen any severe reactions here to speak of. So want to make sure everyone is talking up the vaccine, and that we make sure that we get as many of our fellow citizens vaccinated as possible going forward. So I didn't want to speak for too long. I just want to make sure we get that message out there to everyone. And I'd be happy to stop and take some questions.
If anyone has questions, you are welcome to type them into the chat and we can field those over to Dr. Shewbridge. Okay, so there is one. What can we as employers do and say to encourage employees to get vaccinated without sounding like we are giving medical advice?
We have a one-pager, like a Slim Jim, if you will, of myth busting for the vaccine that can be handed out to employees. I can forward that to you, Stephanie, if you'd like that to pass on to your safety council members. Every company is different as far as how they're sort of requiring or asking employees to get the virus vaccine. I think it's just important to make sure that we combat any misinformation that might be out there so that people are not laboring under a false pretense about something that they think might be risky about the vaccine that is not. So I can forward that to you if folks would like to have that. I know I sent it out to Mr. Coast, who is at Sealy, to share with his employees on the shop floor over there. So I'd be happy to share that with anyone.
Yes, that would be happy to send it out with the recording for this as well.
I'll forward it to Jacqueline and she can get it out.
Wonderful. Are there any other questions that anyone has for Dr. Shewbridge?
I'll jump in with a question. Dr. Shewbridge, do you have any indication on the timeline of when we will actually get through to like non-medical concern people to get vaccinated? Like, I'm not in a high risk category. When can I get vaccinated?
Okay, that's a great question. It looks like the group 2 that I mentioned that have chronic medical conditions is a pretty large group compared to the first group of just high risk older folks and healthcare workers. So it's going to take, I think, probably a month or two to get that group vaccinated. So it's going to be a while before regular healthy folks are going to be able to get it. I'm looking at probably late spring, early summer for the general population. That's just my best guess as far as what we've been seeing and how it's going. I don't know. I see Krista's on the call. Maybe she might want to help me with that, but it's going to be just a little bit time yet before the general population can jump in and get the vaccine. We hope to have the critical number of folks vaccinated by this coming fall so that we don't have to go into winter time again where we all go inside and spread virus. If we're not careful, we want to have as many people vaccinated by next fall.
There is another question. It says many people have signed on different sites. So ArmorVax, the app, Walgreens, Rite Aid, Drug Mart. Is there any better way to get signed up?
Oh, we're encouraging our patients, even our Cleveland Clinic patients, to sign up as many places as possible to get the invitation. We're agnostic to where you get it because it's all covered by the government. So, and is effective wherever you get it. So in order to get at that goal of getting as many people vaccinated as possible, that's perfectly fine with us. What I would ask that is if you do get an invitation to get a vaccination, that you cancel out the other waiting list sign-ons that you've done so that everybody else can move up and you don't have to double check on somebody who has already been vaccinated. Good question.
There's another one that came through. I'm hearing face coverings will still be required after mass vaccination. Is that true? Is it too early to tell?
That's a good question. And yes, face coverings will continue because the vaccine protects the inside of your body from the virus getting in, but it doesn't necessarily eliminate what we would call nasal carriage or a virus that may be on the outside of your body that has yet to get in. So technically, somebody who's been vaccinated may come across somebody who has the vaccine and may have some COVID-19 in their nasal secretions, but it would not nearly be as much as if you were having an active infection, which the vaccine is preventing you from getting. So we still need to mask, wear social distance, and do hand hygiene so we can get to the end of this. So yeah, got to keep doing that in addition to the vaccine. Appreciate that question. Great question.
Are there any other questions? And I'm not seeing any other ones in the chat box. So we will again send out the recording for this along with the information that Dr. Shewbridge is going to share with us. If there are any other questions that you come up with, please let us know, and we could definitely get those over to Dr. Shewbridge. As he mentioned, he is happy to speak with your teams if you are needing more information or more guidance. The clinic is definitely a great partner with the Chamber and Safety Council, and we appreciate your time today.
Thank you very much for having me. Have a great day.
Thanks, you too. All right, so we are going to continue with our presentation today. Again, if there are other questions that pop up, please definitely type them into chat or let Carrie or myself know, and we can definitely get those over to Dr. Shewbridge and his team to answer for you. But without further ado, we are going to turn the floor over to our friends from Cleveland Clinic, Akron General, Kathy and Carmen. They're going to present Stop the Bleed. So ladies, if you want to share your screen with your PowerPoint presentation, they will take questions at the end. So if you do have questions, feel free to pop those into the chat box and we can share those with them at the conclusion of their presentation.
Okay, good afternoon, can everybody see that screen?
Yes.
Yep.
We're good.
Okay, that was the biggest hurdle right there. So we like to thank Stephanie for inviting us to present to you guys today. This is probably one of the first ones we've done in a year since we got shut down because of COVID. So excuse us if we're a little rusty, and this is Carmen's first one. Let me just say, my name is Kathy Cern, and I am the EMS coordinator at Cleveland Clinic, Akron General. I've been here for 30 years. It's a long time. 18 years I worked in the emergency department as a paramedic, and the last 12 years I have been the EMS coordinator. And Carmen's going to introduce herself.
I'm Carmen Restoffer. I am the trauma coordinator of injury prevention and outreach education, and I have been here almost 18 years, 17 in the emergency department, and I'm new in this trauma coordinator role.
So we go back a long way together, Carmen and I. We've worked together for a long time. So what we're here today to talk about is Stop the Bleed. And, oh, don't, okay. I'm not sure how many people have heard of Stop the Bleed because we do this so much. I thought everybody in the whole world knew about Stop the Bleed, but every time we would go and present somewhere, I would ask, and it was amazing to me how many people had never heard of it. And so now I can't ask you because I can't see any of you, but I'm sure there's some of you out there who are not familiar with Stop the Bleed at all. So what we're going to talk about, first of all, what is Stop the Bleed? So Stop the Bleed is a national awareness campaign, and it's intended to cultivate a grassroots effort across the country, which would encourage bystanders to become trained, equipped, and empowered in the event of a bleeding accident. So it gives you permission to step up and do what needs to be done. But we need to understand how Stop the Bleed came about. And so if we look back, and you know, it's a sad thing to look back on, but if we look back on Columbine, April 20th, 1999, when 12 students were killed and 1 teacher and 21 were injured when there was a mass shooting there. And so the shooting started at 11:19 and the shooters committed suicide at 12:08. So it wasn't really a long time to wreak that much damage. The teacher who was shot was Dave Sanders, and he was shot around 11:22. Teachers and students tried to control the bleeding with their shirts. They pulled him into a science classroom, barricaded the doors, and tried to control his bleeding. But at 2:15, and I remember seeing this, and I don't know if any of you had seen it on the news as well, a sign was put up by a student in the window stating, "One is bleeding to death." Well, unfortunately, law enforcement thought that was a ruse by the shooters to get them to come inside. And so they did not evacuate that classroom until 2:40. Now remember, he was shot at 11:22. They called for a medic at 2:40, and by the time the medic arrived at 3 o'clock, Mr. Sanders had passed away. And so you have to wonder if possibly there was a tourniquet, if his life could have been saved. Fast forward to Sandy Hook, which happened December 14th in 2012. 28 people died, 2 were injured, 20 children and 6 adults, including Adam Lanza, who was the shooter, and his mother as well. That shooting started at 9:35 and the final shot was at 9:40. So in 5 minutes, he killed himself, but unfortunately took many lives with him. Police entered the school at 9:45, and they were some people were hiding in closets for as long as 4 hours. Now, things have changed since then. Back then, as I'm a paramedic, and so when I went to school, I'd like to say 5 years ago, but it was much more than that, maybe like 35 years ago. I was only 3. Anyway, I hope you're all laughing with my jokes here. I can't see you, so just pretend you're laughing. So anyway, back when I was going through school, we were always taught medics don't go into any scene until the scene is safe. And these both were obviously very unsafe scenes. The law enforcement had no idea where the shooters were. They didn't know if they were still shooting people. They had no idea what was going on. But that has changed. Law enforcement now goes in immediately with medics. They have what they call tactical SWAT teams. They don't wait any longer to clear that scene, which is a good thing. But another good thing that came out of it, a number of federal agencies, such as the Committee on Tactical Combat Casualty Care and the National Association of Emergency Medical Technicians, got together with some other agencies, including the American College of Surgeons, the Committee on Trauma, and they created the Hartford Consensus, out of which Stop the Bleed was born. So they worked together to figure out all these things, and Stop the Bleed was born out of this Hartford Consensus. And it was launched by the White House in October of 2015. So that's kind of how Stop the Bleed was created and where it came from. Ohio was a little slow initially to jump on the bandwagon, but I am happy to say before COVID, we were like 5th in the country as far as how many people we taught and how many instructors we had. So it caught on. We were doing so many classes. And so it's a little sad for me to see that, we just had to stop and we couldn't continue because we were really making strong headway. But the focus of this program is on what the immediate response is to bleeding and how you as bystanders would recognize what life-threatening bleeding is. And then we're going to talk about appropriate ways to stop the bleeding. So any help given by a first responder, it can make a difference between that patient living or dying, even before professional rescuers arrive there. And so hopefully this training, again, empowers you to act and jump in and do what you can and help save a life. So I always like to say this, but then I forget to tell you before the pictures come up. So
I'll try
maybe
to help.
Carmen will remind me.
I put it
So
on.
there are some images in here that may be, they're very graphic, but it might be what you're dealing with. So if it bothers you, just close your eyes or turn away and we'll tell you when you can come back. And hopefully Carmen reminds me because I always forget. That's what happens when you get old. So why do I need to take this training? So we talked about mass shootings at school, but there's other reasons, bombings, you think about an explosion, and obviously there could be some injuries where there would be a lot of bleeding and you could put a tourniquet on there. But think about home injuries or work-related injuries. And a colleague of ours who used to teach with us and probably will, I'm sure in the future, be teaching with us again. So her cousin owns a small business in Akron, and he was at work on a Saturday. He got a delivery of some chairs and he took a box cutter to open the box and he slit his wrist accidentally. Well, he put pressure on it and it wasn't working, and he got a towel and it wasn't stopping the bleeding. And I believe his wife drove him to an urgent care, which was right down the street. Well, unfortunately, the urgent care didn't have a tourniquet, which I'm pretty sure they probably do now. And they couldn't get the bleeding to stop. So they had to call 911. And they took him to Suma's Trauma Center. It was a Suma urgent care. Not that we wouldn't want him to come to Akron General's level 1 trauma center, but neither here nor there. Anyway, they took him there. He severed his radial artery in his wrist, and he ended up having to go to surgery. He had to get blood products. His blood pressure was really low. He was pretty sick by the time he got to the hospital. And after the surgery, they were able to save his hand, obviously. He's able to use it now. But the surgeon said, if somebody would have had a tourniquet, you wouldn't have had to get blood products. He still would have had to have surgery, but he wouldn't have had to get blood products, which in and of itself carries some risk for people. So, it's just something that you wouldn't think of that you would need to have this for. Some things that happen at work, just like that instance, things that happen at home. You could cut yourself at home. And I'm so concerned about that and so impressed by Stop the Bleed that, the wonderful mother and mother-in-law and wife that I am, right after I started doing this training for Christmas, this was 2 years ago, I bought all my family members Stop the Bleed kits. So if you would have seen their faces on Christmas morning, they were like, thanks, but what am I supposed to do with this? So of course I did the training for them as well, because you never know when something's going to happen, and it's better to have it there and not need it than not have it, and then you're out of luck. So we're going to talk about the immediate response to ensuring safe for bleeding control. So obviously the first thing you want to do is make sure it's a safe environment for you. If you don't feel safe, try to get out of that situation, either by taking that patient with you or whatever you need to do. But we want to make sure that you're safe as well as everybody else, because we don't want you to become a patient as well. So if any of you have had CPR training, there's always the ABCs of CPR. Now it's the CABs, but there are ABCs for bleeding control. So A would be for alert, and that would be that you would be calling 911. So as a paramedic, I worked on my local fire department for 24 years. Now I'm going to tell you, I've been here 30 years and I worked there 24 years, but they went together. Okay. I'm old, but I'm not that old. I just want you to know that. So anyway, when I was on the fire department and we would get a call, I wanted to know as much information as I could when I was driving to that scene. So what happened? So make sure if you're calling 911 that you give enough information so that they're comfortable with what they're going to be dealing with when they arrive to your facility. You also want to make sure, and I know this might seem silly, but you need to make sure that you know the address of your workplace if that's where you're calling from. When I was working in the ER for 18 years, I had no idea what our address was. I didn't need to know what it was. I knew how to get here. I knew how to get home. I didn't have to know what the address was. Now that I'm in this position, I obviously need the address. So, I know it now, but I didn't know it then. I also know if you have landlines at work, what do you have to dial 8 first? Do you have to dial 9 first? Here at the hospital, we have to dial 9. So make sure that you and your employees know what number you're going to be, how you're going to call 911 on your landline. I recommend calling on a landline if you have one, because sometimes the towers, the signal gets crossed and it'll go to a different tower, and then your call may go someplace else where you are not, and so that delays 911 from getting to your facility. So after you call 911, the next thing you want to do is for B, bleeding, and you want to see where that bleeding injury is. Now you're going to have to remove the clothing, whether it's, an arm or a leg, cut the clothing off, whatever it is, because you can't control what you can't see. And if you look at a pant leg that's full of blood, you would have no idea where to compress because you don't know exactly where the bleeding site is. So you're going to think about that. And the C for ABCs of bleeding is compress. So you're going to apply pressure to stop the bleeding. And you're going to do that by covering the wound with a clean cloth. And as it says here, a clean cloth, but also if it's me, use whatever you have. I don't care whether it's clean or not. I don't care if it's a dirty dish towel. We can fix infections, but we can't bring somebody back if they're dead. So I don't think any of you, I know I don't carry sterile gauze in my pockets or whatever. So you need to make sure that whatever you're using, it doesn't matter whether it's clean and sterile, just whatever is closest. Use your shirt if you have to. And when you apply that cloth, you want to push directly on it with both hands. Now, with that being said, Once you do that, you're committed, and you cannot stop that until EMS arrives or somebody takes over for you. So you're committed to holding that pressure for as long as you need to. You can't peak, and Carmen will go into this a little more. So I'm just gonna let her touch on that. You also, if you can use a tourniquet, if you have a tourniquet available, that would be great. Or there's also a third way you can pack or fill a wound. And again, clean cloth, and then you apply pressure with both hands. And again, Carmen is going to touch on that shortly. So again, we talked a little bit about safety. So you have to remain safe. If you become injured, you're not going to help that victim, and you're just going to give us one more person that we have to take care of. Initiate care once that scene is safe. Again, if you feel threatened at all, try to remove yourself from that danger. I don't know if any of you have had ALICE training, and they talk about, seeing, safety and how to get out of a situation like that. So you need to find someplace that you're going to be safe. And then also, if you have gloves available, which I know all of you carry gloves in your pocket like we do, no, not really, but anyway, wear gloves if they're available, you should wear them. So again, we talked about alerting. You're going to get help. You're going to call 911. What you want to do though is, if you're not the only one there with the victim, point to somebody and say, call 911. If you know their name, say their name. I'd say, Carmen, call 911. Because if you just say to the room in general, call 911, everybody's going to think somebody else did, and they're all going to be recording the whole thing on their phones. So you specifically point to somebody and tell that person to call 911. And then again, give them as much information as you can. And depending on what the situation is, police officers will respond to the scene at the same time. So we talked about bleeding. You're going to want to look to see where the bleeding is coming from. Again, you have to open the clothing so you can see that. And so this is the important part for you to understand what life-threatening bleeding is. So it's not just a cut finger that's, oozing a little bit. You don't want to put a tourniquet on that. You really want to look for something that is spurting out of a wound. And I'm going to tell you that Carmen and I, both having worked in the ER for years, when it's an arterial bleed, there's no doubt in your mind. It can shoot across, it's under so much pressure, it can shoot across the room. You won't have any doubt in your mind that that's life-threatening bleeding. So if you see something like that, you need to take care of that. If you see some bleeding that just keeps coming out of the wound and keeps coming and coming, if it's pooling on the ground, if it's soaked through the clothing and you put gauze on it and it's soaked through that, if there's loss of all or a part of an arm or a leg. But saying that, I'm going to tell you that I've seen a number of amputations come in that weren't bleeding because the vessels clamped down, but that doesn't last very long. So initially there may not be a lot of bleeding with an amputation, but it will start bleeding. So even though it's not bleeding at the time, put a tourniquet on that. And then the last one is bleeding in a victim who is confused or unconscious. And this is important for you to know because if you don't know, blood carries oxygen to all our vital organs, including our brain. And so if you're bleeding a lot, you're not getting that blood supply to your brain, and that causes you to be confused. So if your person, your victim, your patient doesn't know what day it is, doesn't know what happened, doesn't know where they are, I would consider them to be confused. And so even though at this point, it looks like they may not be bleeding a lot, that could be because they lost the majority of their blood supply already. And so don't let that, don't hesitate to put a tourniquet on that person just because you think that, you're not seeing any bleeding right now. Carmen just reminded me that there's a picture coming up. So close your eyes if you don't like gory stuff, because that's next. So you can, oh, it's spurting.
Oh, it worked.
Yeah, sometimes this video doesn't work where it spurts out, but you can see how that's spurting. The picture on my left, I think it's probably your, whatever, you'll see it. And then also looking at the next one. I mean, that's obviously, that doesn't take anybody to realize that person needs a tourniquet on. And you can see that the blood is soaked through on the clothing in the sheets. So wounds that can lead to death from bleeding, the ones we're going to use tourniquets on, and then that we talk about tourniquets, are arm and leg wounds. You can't use a tourniquet on a neck, on a head, on a torso. It's only on arms and legs. And these are the most frequent cause of preventable death from injury. So these wounds, again, they can be controlled by direct pressure. And we will tell you that initially, that's probably the first thing that you should try before you put a tourniquet on. Try direct pressure first and see if that works. Now, if you look at that picture of that foot, direct pressure isn't going to work on that one. So you're obviously going to need to put a tourniquet on there. So, but they can be controlled by direct pressure or tourniquets. Your torso-junctional wounds, again, neck, shoulder, groin. And I'm going to repeat this. I'm going to tell you this. We're telling you, Carmen and I are telling you right now, you cannot put a tourniquet around somebody's neck. So whether it's your significant other who's really made you angry, and you put a tourniquet around and said, Carmen and Kathy said it was okay, we're not saying it's okay. No tourniquets around somebody's neck. So those torso-junctional wounds are neck, shoulder, and groin. And those are going to be controlled by direct pressure again, or wound packing, depending on the size of the wound. Other wounds that can lead to death are chest and abdominal injuries. Now, these are a little trickier because you can't see, the bleeding is going on inside and you cannot see it, and it cannot be stopped outside of a hospital. Those patients need rapid transport to an emergency department, and they need to go to surgery as soon as possible. What you want to do with those people, and usually those are maybe gunshot wounds or stabbings to the chest, to the abdomen, to the pelvic area. Those are the ones that when EMS gets there, you want to point those people out immediately to EMS so they transport them first. We can control the bleeding on the arms and the legs, but there's nothing to, you can't control the bleeding on these types of injuries. So identify these patients and send them off to the hospital as soon as possible. So now Carmen's going to talk about compression. We're going to switch seats.
So now let's focus on how to control hemorrhage when a bleeding control kit is not available. So in these cases, you'll need to improvise. So the first priority is to make sure the scene is safe, as discussed earlier. Search for the site of bleeding, even if it means cutting off everybody's clothes. In the ER, we carry trauma shears with us, and that's the first thing we do when a trauma patient comes in, is just cut off all their clothes head to toe. It's more important to save their life than worry about modesty. So you're going to search for the site of any bleeding and determine if it may be life-threatening, and then determine if any bleeding control supplies are available to you. Do you have a first aid kit? If the answer is no, you can control bleeding by taking any available cloth or gauze and using it to apply pressure directly to the bleeding wound. Controlling the hemorrhage is more important than sterility at this point. You don't have to have the special supplies as part of a bleeding control kit. The rapid application of direct pressure to a bleeding wound is a life-saving maneuver until help arrives. If the victim develops an infection from using a non-sterile dressing, they can be given antibiotics later. Direct pressure can control bleeding from anywhere on the body. A firmly applied pair of hands directly onto a bleeding wound can control arterial bleeding, even from large blood vessels, such as those in the neck and groin. You're going to put on gloves if available, then put gauze or your t-shirt or your jacket or a sock on or in the wound and apply lots of pressure, most of your weight, 2 hands leaning into it. Remember, you must hold pressure until you are relieved by the medical responders arriving to the scene. You should not release the pressure to see how well it is working. No peeking to check if the bleeding has stopped. Just keep pushing firmly on the wound to control the bleeding. Applying pressure to a bleeding wound is a painful procedure and will hurt the victim, but it's necessary in order to stop the bleeding. This series of photos demonstrates the procedure. So in this case, the immediate responder is using his shirt. So if the wound is really large and deep, you can stuff or pack the wound with cloth. This will get the cloth deep down in the wound where it is bleeding and help transmit the pressure you apply to the depths of the wound to better control the bleeding. Once you have either covered the wound or packed the wound, you must apply continuous pressure right on the wound using both your hands. This means pushing down on the wound as hard as you can. It's important to understand if the victim's awake, both packing the wound and applying direct pressure will hurt. And talk to the victim, tell them what you're doing. This is going to help stop their bleeding. You're working to save their life. Also remind them paramedics are on their way and they do have pain medicines they can give them at that point. So now let's discuss how to proceed when a bleeding control kit is available. Bleeding control kits come in many shapes and sizes, but they usually contain at least a tourniquet and some other basic essential supplies needed to control bleeding. These kits are becoming more common in public areas. There's an effort to locate them near AED devices in public spaces. As a student in this course, you should start looking for these kits in public places, and you can also suggest to your businesses or purchase and install these kits in places you frequent, like schools or cafeterias or other public gathering areas. These kits are generally not too expensive. They're easy to install and maintain. The first thing we need to do is determine the location of the wound. Is the wound on an arm or a leg? If the answer is yes, then we need to see if the trauma kit contains a tourniquet. If the tourniquet is immediately available, place the tourniquet on the injured arm or leg. Be sure it is above the bleeding site. That means closer to the heart. Tighten the tourniquet until the bleeding stops. The next picture is pretty graphic too. The next slide. So let's talk about modern tourniquets. Tourniquets are devices that put pressure on blood vessels above the site of a serious wound in order to stop ongoing bleeding. When a tourniquet is properly applied, it will prevent all blood from getting into the injured arm or leg and thus stop the bleeding from the injury. Excessive bleeding can result in shock, and shock occurs when there's decreased delivery of oxygen and other vital nutrients to the organs of the body. Blood is the main delivery vehicle of these vital substances, and the decrease in the amount of functional blood cells in combination with the decreased blood pressure that results from shock can result in permanent organ damage and eventually death. A recommended commercial tourniquet can be a life-saving device. There should not be any hesitation about using one when there is life-threatening bleeding from an arm or a leg. So the key point, above the bleeding site means further up on the arm or leg, not right over top of the wound. You can place a tourniquet over the victim's clothing if the time is critical and you can't get the clothing off. So you're going to tighten the tourniquet until the bleeding stops. If you've made the tourniquet as tight as you can and the wound is still bleeding, you can apply a second tourniquet if it's available on the extremity just above the first one. If the second tourniquet is not available, apply direct pressure on the wound.
Talk about the elbow, the knee joint and the elbow joint.
Yeah, you go ahead.
Okay.
We're switching again.
Okay.
Now it goes on to all the tourniquets.
Okay, so as Carmen said, you're going to apply it 2 to 3 inches above the wound. And that is what the American College of Surgeons recommends. But keep in mind that there are other ways to do this. I think the military, they do what they call high and tight. So if it's something in an arm, they'll go right to the top of the arm or the top of the leg. And that way, it's going to stop any bleeding, not only from the site that you see, but if there's more than one site. So either way is not wrong. Either 2 to 3 inches above the wound or high and tight, whichever is your preference. You do not want to apply the tourniquet over a knee or an elbow joint, and that only makes sense if you think about your elbow. You would not be able to tighten that down enough because those bones are in the way. So you want it actually over the fleshy part. And you don't want to obviously apply it over a pocket that contains a bulky item, a wallet or a lighter or something like that. Anything that's going to stop you from being able to tighten that down. And you want to tighten the tourniquet until the bleeding stops. And so keep in mind, this is going to be, as Carmen said before, this is going to be extremely painful. And they are going to be begging you to take that tourniquet off, and you cannot take it off. That's number one, do not remove it once it's been applied. It's going to be very, very painful, but just let them know that, EMS is coming and they have good drugs in their little drug boxes. There are different types of tourniquets. We recommend the CAT tourniquet, C-A-T, it's Combat Application Tourniquet. This is what the military uses. It's also what law enforcement uses and now the fire departments, and that's what we are recommending. I will tell you that you can go on Amazon and buy tourniquets. They have what they call CAT tourniquets, but they aren't the real CAT tourniquet. These things are not cheap. They're about $30. So if you're paying $12 for a tourniquet, that is not a CAT tourniquet. When we had our training, when we became instructors a couple years ago, we had CAT tourniquets and somebody brought one that they got on Amazon, paid $12 for, and it was very difficult to use. Everybody in the room, all EMS professionals, or there was a couple of physicians as well. None of us, we all had difficulty using that $12 tourniquet. These are much, much easier to use. There's a couple different generations, but if you go someplace to purchase these, and we'll talk about where you can get them, if you're, again, not paying $30 for that tourniquet, it's a knockoff. So don't be fooled by that. So it's the military's preferred tourniquet. It's easy to use. It can be applied rapidly. You can apply it to yourself. And that's why people in the military carry one on them all the time. And so if somebody gets hurt, their rule is, if you're taking care of somebody that's hurt, you use their tourniquet, not your tourniquets, because you may need yours, whatever. So it's very easy to apply to yourself. And, unfortunately, we cannot do any of the hands-on, but if we come out to your companies to give this presentation, we will show you exactly how that works, and you'll be able to apply them to yourself. So the first thing you want to do is insert the wounded extremity through the tourniquet. Now, I recommend looping the tourniquet and having it ready to go rather than trying to fumble around and feed the strap through there. If you already have it looped through, you just put it right on the arm or the leg. And you want, again, remember, 2 to 3 inches above the wound. Now, this to me is the most important part of applying a tourniquet. You're going to pull that band as tightly as you can and fasten it back onto itself. It's Velcro, so that if you see what he's doing, it'll come back around and come around to the other side up until it gets to the clip. They can't see me pointing. Up until it gets right to this clip. So you're gonna go all the way around the back and pull it right to and stop right here. If you don't get this part tight enough, you're never going to stop that bleeding. So that's the biggest mistake that some people make. So make sure that you have all that slack removed and make it as tight as you possibly can. Adhere the band to the extremity and don't go past that clip, as I said. And you can see right there, that's where the clip is. I don't know if you can see my little arrow. So this rod is called a windlass rod. Once you have that strap right here, you're going to start turning that windlass, and you keep turning it until the bleeding stops completely. Now, if you have to turn that more than 2 or 3 times, you don't have the band tight enough. So you're going to back off and start over and pull that band tight. Once the bleeding is stopped, you're going to place that windlass rod into the clip right there. And now the bleeding should be controlled. Then you want to take the remaining band that's left over, and you're going to feed it through that clip and continue around the extremity as far as it will go. Now, if it's a smaller person, that band may go all the way around another time. If it's not, you might want to fold it back onto itself, because you don't want that strap hanging down, where as you move that patient, it could get caught on something and then release the tourniquet. And you don't want that to happen. So once you have that strap secured, there's a little white band. You're going to pull that band across and adhere it to the other side of that windlass clip, as you see there. And then you want to note the time that that tourniquet was applied. If you have a tourniquet and a kit, there's a magic marker in there that you can write that. And the reason that's important is because the surgeons need to know how long that tourniquet's been on. There's never been any studies done or any research into the fact that if you have a tourniquet on for 2 hours or less, you would lose an arm or a leg. That has not happened. They've even done some studies that show that you can even go longer than that. And if you think about orthopedic surgeons who are doing, knee replacements or whatever, or some other type of surgery, they have tourniquets on those extremities for hours, maybe up to 8 hours, and they're fine. So don't be afraid that if you leave it on too long, it's better to lose a limb than to lose your life. And now that patient is ready for transport. So some of the key points we're going to talk about, improvised tourniquets. While I'm telling you that the best tourniquet for you to have is a real cat tourniquet, if you don't have a cat tourniquet available, use whatever's at your disposal. A belt, a towel, a tie, whatever you have. The only thing you don't want to use is a shoelace, because the shoelace is too skinny and it causes more damage than it would help. So if a commercial tourniquet isn't available, use whatever you have, but it's going to be a little more difficult to apply it. So if you don't have one, you can practice. Don't tie it really tight, but think about that. Again, as Carmen said, if it hasn't stopped with one tourniquet and you know you can't get that thing any tighter than you've already have it, use the second one right above the first one and tighten it just like you follow the same procedures that you did for the first one. So again, key points: no amputations have been caused when tourniquets have been left in place for less than 2 hours. But it is the best practice is to get them to a trauma center as soon as possible. Again, better to risk damage to the arm or leg than have that patient die. If we are able to, once we are able to come out and do training again, the tourniquets we use are blue. Those are training tourniquets. You don't want to use those in a real situation, but I will tell you that when we're at your facility, and if something happens while we're there, we're using whatever's at our disposal. So if we have blue tourniquets, we're using blue tourniquets. It's just that we've trained on them so much that they may not be quite as effective. So as Carmen alluded to, tourniquets hurt a lot. I have a kid that I used to work with on the fire department. He was full-time on another fire department, and he was telling me that this was a couple summers ago. He had a big strapping guy was in a motorcycle accident, and I don't remember what the injury was, but he applied a tourniquet, and this guy was crying and begging him to take that tourniquet off because it hurt. You cannot do that, and that's probably going to be one of the hardest things, is not to remove that tourniquet. It doesn't mean that you put it on wrong. But you should not take it off. Once paramedics arrive, they will treat that patient with medication. Some of the common mistakes, and I know it's a hard thing to think about, is like, is this life-threatening bleeding or isn't it? Always err on the side of, yes, it is life-threatening. If you any doubt in your mind that it's life-threatening, put a tourniquet on, because that's usually the biggest mistake that people make. Again, as I said, not tightening it enough. Not using a second tourniquet, loosening it. Now, I'm going to tell you that I'm one who likes to see things. You know, I cut my finger and I put pressure on it, and then I keep looking. I'm very nosy like that, which is one of the reasons I got into EMS, because I can be right in the middle of things. But you cannot look. When, as I said before, once you put that pressure on, or you have that tourniquet on, you're there with pressure, especially, you're there for the long haul. You're committed to that until somebody relieves you. And with a tourniquet, you cannot loosen it to see if the bleeding has stopped. You do not, now, and I know on this slide, it says only a paramedic or physician should loosen it, but I'm going to tell you, I don't know any paramedic that would loosen that tourniquet. They're going to leave that tourniquet on, and then it's up to the discretion of the physician when they get him to the hospital. Anybody have any questions about tourniquets? We'll save the questions till the end when it's a little bit early, easier to go into the chat. And so now Carmen's going to again talk about packing wounds.
So now let's discuss what to do if your trauma kit does not contain a tourniquet. So in this case, the wound is on an extremity, but a tourniquet is not immediately available. If a tourniquet is not available, but a bleeding control gauze, also known as a hemostatic dressing, is available, the gauze should be packed or stuffed into the wound and then pressure applied directly on the wound. If a bleeding control gauze is not available, then any clean cloth or plain gauze along with direct pressure can be used as described before. If the wound is instead located in one of the junctional areas like the neck, shoulder, armpit, or groin, and a bleeding control kit is available, the gauze should be packed or stuffed into the wound and then pressure applied directly on the wound. If a bleeding control gauze is not available, again, any clean cloth will do. The word hemostatic is a medical term. It means stopping the flow of blood. Hemostatic dressings are usually gauze rolls that have been impregnated with a material, substance, or substance that will help the blood clot. This slide lists the most commonly available hemostatic products currently available on the market. So like QuikClot has a shelf life of 5 years, but if that's what you have in your kit and it's been there for 7 years and you have a wound that you want to use it on, it's fine, just use it. It's still a clean gauze. So let's go over the steps for packing a wound with a hemostatic dressing or a gauze roll or even a clean cloth. So first you have to locate the wound. So you're opening the clothing over the wound to expose it. So if you see a lot of pooled blood around the wound, remove it from the wound by very gently wiping it away. You want to try to leave any clots in place so it will stop bleeding if possible. Then look into the wound and try to find the point where the bleeding is coming from. Even large wounds typically have only 1 or 2 places that are actively bleeding. Locate the source of the most active bleeding. Then pack or stuff the hemostatic gauze or plain gauze or clean cloth directly into the wound, down into the bottom of the wound and right under the point of the bleeding. Don't just plop the whole gauze on top of the bleeding, but unroll it and feed it in a little bit at a time until no more can fill up the hole. The top image shows the correct way to pack a wound. Packing material stuffed down deep into the base of the wound as close as possible to the actual source of bleeding. The lower image shows the incorrect way to pack a wound. If the wound is not packed properly, pressure cannot be applied to the actual bleeding site and the bleeding will continue. Once you have packed the entire dressing into the wound, apply and hold firm pressure using both hands. When you apply the pressure is transmitted down to the bottom of the wound toward the source of the bleeding. If you note that the packing you place has become completely soaked with blood and the wound is continuing to bleed, just take a second roll of gauze or another shirt and pack it right on top of the first one and reapply pressure. And again, we'll answer questions about wound packing and direct pressure at the end. So bleeding control in children, techniques to control bleeding in the child are very similar to what has been presented for adults. As long as they can be properly applied, the same tourniquet can be used in an adult or child. If the child is too small for the tourniquet to be applied properly, direct pressure on the bleeding wound will almost always work to control the bleeding. And wound packing is the same in children and adults. So exposure to blood is not uncommon in these circumstances. Like we were talking about, do you have gloves with you? I do keep some gloves in the trunk of my car just in case I come across an accident, but most people don't have gloves on them. So, you know, you are going to be using a shirt or something on top of it. So hopefully the exposure to you will be very minimal. If you have intact skin, the risk of transmitting diseases to you is very, very slim. However, once the EMS arrives, you can tell them, yes, I was exposed to someone else's blood. Wash any blood on you thoroughly with soap and water to remove it. Notify them, let them know. They might want you to come into the ER to be tested, and they'll test the patient as well to see if they have any of the, you know, Hep B or HIV. So to summarize everything we've talked about, first, you want to be sure the scene is safe for you to assist the victim without risking injury to yourself. You do not want to become a trauma victim yourself. And then let's review the ABCs of bleeding once again. A is alert, either call 911 or the local emergency number yourself or direct someone else to do so. This will ensure that trained help is on the way along with law enforcement depending on the situation. B, for bleeding, locate the victim's wound and determine if there's life-threatening bleeding coming from the wound. This will most often mean opening up the clothing and exposing some of the patient so you can see the wound. And C, compression, do what you can to stop the bleeding. This usually means compressing the bleeding blood vessel, either directly using 2 hands, using a tourniquet on an arm or leg placed above the wound to compress the artery, or by packing the bleeding wound and then applying pressure on it with both hands. And the only thing more tragic than a death is a death that could have been prevented. And we thank you for your interest in the Stop the Bleed and your attention. We'll get to questions in 1 second. These both, right, Kathy, you can go to bleedingcontrol.org and you can order yourself a whole Stop the Bleed kit if you want, which comes with, you know, the tourniquet and gloves and the quick clot gauze. Or they also have larger kits that could be mounted, you know, for a business. And then this is, again, the bleedingcontrol.org website and then our information. Is there any questions?
I am not seeing any questions. I think just because we're kind of running short on time, if it's okay, I was going to share my screen to go over the BWC stuff.
Okay.
Actually, the one question we did have you answered, so that was good, about where to find the kits. And if we have any more, then I will just answer those as they come through. So I will share my screen. I'm still not seeing any questions, but let me share my screen. I know it's showing funny. My was running super slow. you guys got yours on a whole lot quicker than I did. Just a couple BWC and Safety Council talking points. One is no semi-annual reports. I know a lot of folks have been asking Stephanie about that, so don't worry about those. I am still here for you virtually at this point. Okay, now it's like scrolling through the slides without me doing it. I am still here for you virtually. There is some webinars coming up. The reason I left the accident analysis one on there was because if you are in the drug-free program and you need the accident analysis online training for that program, you can take it through just by watching the replay and keep your own sign-in sheets. If you have questions on that, just shoot me an email and I can help you with that one. But we do have other webinars coming up here just in February, March, and April. BWC classes at this point are still all virtual. So know that, oh my goodness, know that you can sign up for those, and there's a list of those, and those are all on that website, the bwclearningcenter.com. The one thing that Stephanie is gonna, or one of the things that Stephanie's gonna include in the follow-up to this meeting is a new BWC Hazard Communication micro video training series. And if you are looking to updo or do your HAZCOM training, this is a really good series that has a training guide and knowledge assessment. And then it's 4 short, less than 5-minute training videos that you can use and have folks work themselves through those videos. And the last thing I had is Ohio Safety Congress. Registration is open now. And actually that will be before our next meeting, believe it or not. So it has come up on us quick. Registration is open. They're doing 2 days. It is 100% virtual. It is free. If you have not registered for Safety Congress yet, make sure that you do that and you can go from there. So that is my stuff that I had sharing. Let's see, Kathy, can you guys show up or throw up your last screen there that you had your contact information?
Sure.
And it looks like Stephanie also is going to include that later. If an employer wanted to, I know one question I had, if an employer wanted to do this training at their facility, even like right now and do it virtually, is that something that you guys are willing to do or able to do, or is there somewhere else that they should contact through there?
We could do it that way, but we really prefer to do it in person because of the hands-on part. You know, it's one thing to talk about how to put a tourniquet on, but it's another thing to actually put one on and go through the steps. You know, it's just, I mean, if this thing doesn't go away soon, COVID, then we would be happy to do, you know, do it virtually, but we would really prefer to be in person. So.
I don't blame you. I'd prefer to be in person too.
I know, right? Can
Yes,
you see my
100%.
screen right now with the information? Can you see that?
Yes, yes.
Okay.
I see your and Carmen's email and phone number. So it's kind of small, but it's fine. They'll be able to see it.
I
And
can make it
Stephanie can
bigger.
include that.
I can
Yeah,
make-
Stephanie can include that too. So
Okay.
any other questions? If you guys have questions, go ahead and throw those in the chat. Stephanie, did you get any other questions from folks directly to you?
No, I didn't see any other questions. And I know, like, in the interest of time, we're hitting that 1 o'clock time frame. So we thank all of you for sticking with us. Thank you so much, Kathy and Carmen, for your wonderful presentation today. Dr. Shewbridge did send that one sheeter over that he talked about. So following this, again, I will be sending out the link for this presentation, as well as the information that Dr. Shewbridge sent for the vaccine. We will include Carmen and Kathy's information in that email as well. Please feel free to reach out to them if you do have questions or you're looking for more information about any of the resources that they provided. They are happy to answer questions. We will be doing Safety Council again next month. Mark the 3rd Tuesday of every month on your calendar. Next month, we will have somebody from Alternative Paths talking about mental health and wellness. So that will be Tuesday, March 16th at 12 p.m. You'll see registration go up within the next couple of days for that. So thank you again for joining us today. There was one question, Kathy. Somebody asked, how long before you think you'll be able to do in-person training? Do you have any idea?
We're from the ACF, American College of Surgeons. They recommended like after the end of March. So maybe April, May. I mean, if it's a small class, you know, I wouldn't be comfortable doing like 50 people, but if it's a smaller class with, you know, a handful of people, I think we would be comfortable coming out and doing that. And again, Carmen and I have we've both had our vaccines, both of them. So, you know, we're comfortable going out in public, sort of. We'd still be masking though, so.
Perfect. All right. Well, thank you again, Kathy and Carmen, for sharing your information with us today. A thank you again to Dr. Shewbridge for sharing the information about the vaccine. And then stay tuned for an email with follow-up with information from this presentation. Have a great day, everyone, and we will see you soon.
Thank you.
Thanks, guys. It's good to, virtually see everybody.